I see Pam's here. I'll call it to order. We won't, we'll dispense with approval of the minutes. Pam, you're on, correct?
Yes, she's here.
Yeah, I'm here.
Okay, on the data request information, I haven't received anything. Did I miss that?
No, you haven't. There, so a lot of this, I need to talk to you all about narrowing down. I do have some on the discharges. Unfortunately, a lot of this has been a huge manual effort, or we've had to really look through the data. So for example, I've got the discharge. Let me give you the discharge information. So for 2018, there were 30 involuntary discharges, and these are all residential. 12 of those were receiving exceptional supports. In 2019, there were 14, and 5 of those were receiving exceptional supports. In 2020, there were 17, 10 of those were receiving exceptional supports. And in 2021, there were 11, with 3 receiving exceptional supports. Now, as far as the timeline of how long they continue to reservices, that's a little bit harder because there's not a lot of documentation. The service providers weren't uploading documentation, which at that point, and it still is not required for them to use MWMA. We still, they still are allowed to keep the documentation in their own system of record. And so I've been reading individual case management notes, and many times there's no reference to whether things have resolved and the person decided to keep them, if they're still looking for additional, looking to transition them to a different location. All of that is still, it's kind of a mystery. There's not a whole lot of information. So I'm working with the MWMA team to see if we can add something to the system that'll help us track this, that'll help us track it better, because I know those numbers don't line up with the surveys that you all have, that I know that CAP, the last survey I think that I saw that Amy's group had done, but those were the numbers that were given to us by BDID, that BDID had tracked.
How many exceptional supports did you say in 2020? I didn't quite catch that number.
10.
10, okay.
Hmm.
All right, well, you'll be sending that out to me anyway.
Yeah, I can send it out to you in writing. Yeah, I can send something out to you. So
okay.
now then the next one was the number of unclaimed crisis hospitalizations. So there is not a specific flag on the hospitalization, whether it was for a crisis or whether it was just a hospitalization. So we have gotten all of the, I have all of the hospitalization and ER visit information for that time frame. And really I'm having to look at the diagnosis for each one. If there's any particular diagnosis that you all would be interested in seeing, I can narrow it down that way. Otherwise, I'm going to have to basically, we'll just have to give you kind of a, these are the number of hospitalizations here, kind of the primary diagnosis for the top 5 or the top 10.
Okay.
Same thing for ER visits. So I can do it that way.
That sounds good.
Okay.
Yeah, the top 5 sounds good.
Top 5, okay. And do you want me to go ahead and bring 21 into that now too? Because I know we had done
Sure.
18, 19,
Yeah.
okay.
Sure, thank
Okay.
you.
All right, and then incident reports. So I was actually just looking at that just a few minutes ago. So we, because prior to 2020, we were doing the incident reports were all done, they were faxed in, and then we rolled out towards the end of that, we rolled out MWMA. So I have more data there. What I'm having to do right now though is there's some duplicate, I'm weeding out the duplicates because we may have had the same incident reported twice or 3 times, depending on if it was reported by the case manager and the service provider. So I want to make sure we don't count anything twice.
Okay,
And then also some of the incident reports are, I'm going to give them to you in categories because some of them, they may be somebody receiving exceptional supports, but the reason they had an incident was because, they got sick and had to go to the hospital. So, I mean, it wasn't anything necessarily related to what they were on exceptional supports for. So I want to give you a little bit of context around that information so that it doesn't sway the data one way or the other. But so I'll give you that, and I'll break out the categories of the incident report. And do you want me to compare that to the non-exceptional support population?
that would be great.
Okay.
How about units of service? Were you able to come up with that?
We are, so I had 18, 19, and 20, but I had the dollar amount. We actually are refreshing that data right now because we're pulling in 2021. So I will have that for each year for each. It'll be based on the fiscal year. So we're doing fiscal year 18, 19, 20, and 21.
Thank you. We'll look forward to that. Pam, I know that's a lot of work.
I feel like I've been telling y'all it's coming. I mean, I have been really working on it. Of course, then we have the tornado that disrupted.
I get it.
There were several things that kept disrupting and working on it, but we have been working on gathering it. So
right, a lot of issues. The next item is COVID protocol updates. If I'm not mistaken, the protocol we have now was developed before vaccines and boosters. Is that correct?
So we are following the guidance that that the CDC puts out. We have not
Okay,
we're not issuing any, we send all that information out, just as guidance and as FYI, but we as far as us saying anything particular or giving any directions, we're not doing haven't done anything different than what we've been doing all along and what the CDC recommends.
Okay, for some reason I thought there was like extra protocol with exposure and things like that. So we just use the CDC protocol. That's good.
Yeah, you do follow what the CDC has posted.
Yeah, and no extra protocol beyond that.
We have not added anything on to that, correct?
Okay. The FMAP, I guess bonus at 10%, that's referred to as you're going to be making some investments. Have you using that money? Has that been narrowed down any or determined?
We've been working on we're working on our project plan, so there's more information that'll be coming out on those soon. We're still waiting on our final approval from CMS. We still are operating under the partial approval, but there'll be more information coming out soon. Rate study will be we are doing the kickoff for that and are internally and going through the what our next steps are for data gathering for that. So for sure more information will be coming out about rate study, but there'll be we'll be holding some more webinars and things as far as when we have more of those the project once it is outlined more in more detail and have more information to share. We'll start having more stakeholder sessions.
Yeah,
but, I believe the spending plan right now is on the is still posted out on the website. So
I assume when you talk about rate study, you'll be hiring some company to do that.
yeah, we will have a consultant that will that has experience and has the knowledge to be able to do that and the staff to be able to do that. Yes, we will be bringing in a group again to do that.
Charlie, I can't see, all I can see is the agenda. I don't know if anybody has a question or anything or, okay, there's nothing in the chats, never mind. Okay, that's good to know. And am I correct that the Appendix K extension has been extended?
Yeah, so there's two, okay, so there's two Appendix Ks in effect right now. The pandemic Appendix K, which the current end date is 6 months past the end of the public health emergency. And as you all know, it was just extended. So that is still in effect. And then we also, at the end of December, we did an Appendix K for the participants and providers that provide services in the counties that were impacted by the natural disaster. And so that is currently in effect right now until the end of June.
Okay, good. I understand SSI income is going to go up. Is that?
There was a COLA, so there was the cost of living increase, the adjustment that was done, and I believe all of those were done at the beginning of January. So all of that is done systematically, and there were some adjustments accordingly to patient liability. Everyone may have received an addition, another document about their patient liability, but I do know those did go into effect in January.
So I guess that would, it says it's 300 times what the benefit and
that stays, the patient liability, correct, is still the same. It's 300% of the
Okay.
FBR. Yeah.
So the patient then really has a larger deductible, let's say, right? Or,
I did not, from what I have seen of our individuals, I didn't see where we had anybody that were really impacted or any
Yeah.
huge changes to patient liability.
Mhm.
But it potentially could have made them have, where if they didn't have a patient liability, they could have one, but I have not seen that be the case.
That's good. That's good. And it's good Kentucky raised the patient liability limits at 300%. Well, finally, waiting list. What do you have for us?
Let me get to that page again really quick. Okay, so for SCL, we are at 2,943 total. 108 are on the urgent list, and 2,835 are on future planning. For Michelle P, we are at 7,510. Of those, about 77% are children, so it's at 5,803 right now, are under 21. And we have been allocating, as you know, we've allocated about every 90 days. So in 2021, we actually allocated 919 slots for on the Michelle P wait list. And then in mid-January, so we've allocated another 150 just recently.
Back on the SLL, you said critical. Is it 0 on the emergency?
0 on emergency right now, yes.
0?
Uh-huh.
Very good. And Michelle P, where do we stand on some kind of pediatric protocol?
So there is part of that, part of the ARPA funding is looking at a validated assessment tool as far as the wait list. It's also looking at the wait list and what we can do to reduce that wait list. Now, I know it's probably been about 90 days ago or maybe 6 months ago, I did an analysis of the individuals on the Michelle P wait list in particular. And over 50% of them, and I think it really was over 70% of those individuals have Medicaid already. So they can be receiving some type of assistance. Most of them also qualify. They have parents that have private health insurance, so they may qualify for, their families may qualify for the KI HIP program. So part of what we're going to do with wait list is we want to look at it to see, if there's anybody on the wait list that maybe could be served. They maybe need therapy, or there's some services they could be receiving outside of the waiver and don't really need the waiver for those services. So
so there might be some people leaving the waiver.
So
then?
there potentially could, yes. I can't say 100%, but we do want to take a look at the individuals that are making up the wait list to see if their needs could be met in a different manner versus on the wait list.
And if you make that determination, yes, their needs can be met in another manner. Did you say you thought there would be quite a few such people?
I don't know. It's too
based on
early for me,
initial-
really. It's too early to really say that
Okay.
without looking at the data and really having that plan finalized. So,
You-
but we do want to look at all aspects of it. And even if they were to choose to remain on the waiver, we do this for any individual on the wait list. We want to make sure that if they're on a wait list for a particular waiver, are there services they could be getting right now that meets their needs? So it's really a holistic view of everyone on the wait list.
Is that something you're pursuing independently, or is that part of the rate study, or?
It's not part of the rate study, but it's part of our
Oh,
and-
that's right, using the FMAP money. Right.
using the FMAP money. It is part of what we outlined to
That's
see.
right. That's right. Do you have any goal as to when that would be completed?
I do not right now. We will though have more more communication to come very soon on that. We'll start sharing some dates and some target dates and some goals and milestones.
Okay, we look forward to seeing that. Back on the pediatric assessment, does such a thing exist, or does it have to be created from scratch?
Well, we're not, so right now our goal is to find a validated assessment tool. So it's one that already exists
Uh-huh.
with a validated methodology. So we are in the initial research and phase of that. So we're looking at what other states are using, what they have found to be effective. There are some states that do have that target children's populations. So we feel like they're going to be a good resource to help us for capturing that information and to see what they're doing. So
it sounds like you're fairly confident that does not need to be invented.
correct.
Correct.
Correct. No, there are multiple validated assessment tools out there right now. We're just in that research phase, looking at which ones other states are using for what populations, how effective that they've been. And as part of the FMAP, the rules, we cannot put anything in that creates a stricter eligibility than what was in effect of April 2021. So, we have to approach this very carefully and very methodically. So we, are looking at them. We will look at, we'll want to do a kind of a pilot or a side-by-side study to make sure that we don't have any unintended consequences, if we choose something different. So there'll be several steps to implementing a new tool. But definitely talking to some of our sister states and other states that have children in the waivers that they serve is going to be an important step to learn from, what they found worked, what they found didn't work.
Tell me that date again, that moving forward, up to that point, you can't.
April 1st, 2021.
Okay. And it's after that date, you can have more stringent.
No, you cannot have anything that you put in after, and it's in if you look at either the state Medicaid letter for the American Rescue Plan Act, or if you look in our spending plan, our narrative that's posted on the website, those conditions are all listed, I think close to the top of it. But it talks about that you can't impose stricter standards than what was in effect on April 1, 2021.
Oh, so it may not be possible to make any substantive changes.
It depends on what. So I think that you have to be careful how you look at it, and so we want to focus on gathering information that makes sure that individuals are receiving the right types of services and the right amount of services.
Yeah.
But we couldn't come in and just change the eligibility criteria. So for example, you couldn't come in and say, okay, this waiver no longer will serve individuals under the age of 18.
Oh, I
that
see.
directly violates it.
Okay.
But you can bring in a tool that helps you collect more validated data. So
okay. That better determines that they have a disability.
correct. Yes.
Yes. Okay.
Yes, but
Okay.
you couldn't come in and just say, okay, now this person no longer, this diagnosis or this age no longer qualifies. You're not allowed to do that.
Right, whole demographic
Correct,
categories. Right,
correct.
right. Well, that sounds good. Is there any other comments? I think we've exhausted our agenda.
Can I ask a quick question, Rick?
Sure.
Okay, Pam, on the, for, people that are on the waiting list, and you said there's other services that people can receive through Medicaid services, are you all seeing a big increase in people requesting, services from like throughout the state?
Honestly, no. And so there's a couple things that I think that contribute to that. One is they just don't know. If you don't know what to ask for, you don't know what's out there, then
Well, that's what
you're
I'm
not gonna
thinking.
seek it. So we're working on, so to address that, we're working on some education. We're working on some like really simple, like one-page things that'll go out to participants, and we're working on some information to include some training with the case managers, as well as some kind of leave behind information that they can give to the participant that says, okay, I've been placed on a wait list, now what? Or I'm on a waiver, what does that mean? Because we even see individuals that are on waiver that need other services
Yeah.
that they don't get just because they don't know that they have, they don't know that they can get DME. They don't know, that they can get behavioral health services. Unfortunately, the other thing that we see is that we have individuals that come on, and this is Michelle P in particular, where there's a 40-hour-a-week service limit, and they come on and they exhaust all of that in just attendant care. And so the individual maybe could benefit from other services, but because, and this in particular happens with children, they get pushed to put all those hours towards attendant care. So we're really wanting to do education on that and focus on making sure people understand, what services best meet their needs and how to access them.
Yeah, that's what I was thinking. They weren't really sure what they would qualify for.
Correct. So we're working on helping with that and doing some education.
Okay, just to make sure I understand that, there are some people perhaps who would have better access to services like therapies if they were not on the Michelle P waiver.
No, I mean, they could. So it's two things, Eric. So they would have they have access to those state plan services, even if they're on Michelle P. So it's, them knowing what they have access to and how to gain those services. The other is when they're on Michelle P, because regulatorily there's a 40-hour limit, outside of respite, that they're looking at it saying, I want all 40 hours for attendant care. And so then that doesn't leave them any hours to maybe access behavior supports through Michelle P. Or to maybe go to adult day. Because all of the hours are being dedicated to attendant care. And unfortunately you see that most of the time when it is a child and it is a parent who's a paid caregiver. It's just the reality of what it is.
Is it your belief though? I mean, some people would be advantaged by not being on the SEL, on the Michelle P waiver?
I don't know that it's really an advantage. I think it boils down to what is the right type of services that an individual needs, and where is the best place for them to get those services, or what is going to benefit them the most. So it's all individualized. It's going to vary from person to person. It's not necessarily that somebody doesn't need to be on the waiver, but it's all about their plan being person-centered too. So what is important to them? What goals do they want to achieve, and how do they want to live their best life? So it really is holistic. It's about the person, it's about what they want, and it's about what is going to benefit them the most.
They would be giving up case management services, I guess, if they leave the waiver.
And then I'm not advocating for anyone to leave the waiver. What I want to see is just that individuals get opportunity to receive the services that they need.
Gotcha.
And that they're able to participate in those, and that it's truly person-centered, and it's about the person and what that person needs and what is going to benefit them the most.
So providers would be wise to be prepared to deliver both waiver services and non-waiver therapy.
Well, they're not necessarily, they may or may not be the ones, because
Yeah.
they may be enrolled in state plan.
Right.
But, you know, those team meetings really need to include, what does the individual want to do? What does the individual need? And how do we connect them with those, whether it be through waiver and be a waiver provider, or whether it be that they need a specific piece of DME, or they need a
Right.
therapy service.
Okay.
Okay.
Well, that sounds good. Any other questions?
Thank you, Pam. Thanks, Rick.
Yeah, thanks, Patty. If not, I guess we'll adjourn. Okay.
Quick. I'm good.
Okay.
Thanks, everybody.
Goodbye.
Bye.
Thank you.